What will be the definition to say this condition? What are the other conditions you think could be associated with it? What are the complications of this condition? And how will you treat her? We have another clinical picture of a 45-year-old male who came to the OPD with rashes all over the body since last night. Patient also gave a history of having taken antibiotic linezolid yesterday for some other problem. He on examination is conscious, oriented. BP was 110/70, pulse rate was 94 minutes. With this, what will be your clinical diagnosis? And how will you manage him? Next, we have another interesting ECG for you. A 35-year-old male who came to OPD for his routine health checkup. In that, the patient had taken an ECG. What do you think are the findings in this ECG? With this, what will be your diagnosis? What is short PR interval? What are the causes you can think of for a short PR interval? So as you think over the causes, how will you think you can differentiate this LGLS Lorn-Ganong-Levin syndrome from Wolff-Parkinson's-White syndrome? With this, I think would have got the diagnosis. So what are the complications you can think of which could be associated with this condition, and how will you treat him? Next, we have a 51-year-old male, a chronic alcoholic and smoker, who came with on and off epigastric pain radiating to the back since 2 days, and also a history of having vomiting 4 episodes. He was afebrile, pulse rate was 96 per minute, BP was 130/70. Per abdomen examination, it was tenderness in the epigastric region. Other systemic examinations were normal. With this history, what will be your clinical diagnosis? How will you proceed to evaluate him? An ultrasound and a CT abdomen was taken for the patient. The pictures are shown here. What are the findings you can think of in this picture? You can see in these pictures. With this, what will be your final diagnosis and how will you manage him? Another 50-year-old female, a known case of decompensate liver disease, present with fever and breathlessness and cough for the past 1 week. On examination, she was conscious, oriented, tachypneic, saturation was only 76% at room air, BP was 150/90. On auscultation, bilateral V's and bilateral Krebs were present. Her liver function tests were all altered. Her bilirubin was high, albumin globulin, there was a dissociation, flapping tremors were present. Ultrasound abdomen showed on decompensate liver disease, and ABG was done for her. Routinely, she was stabilized. Type 1 respiratory failure was seen in the ABG. This is her first X-ray. What is the findings in the X-ray? You can see. With this, how will you proceed to evaluate her further? What are the complications you can think of for these conditions? With this, what will be your final diagnosis and how will you manage this patient? And I take the pleasure to make one announcement that we are having the most awaited conference of the year, ACME 2025, on April 13th, 2025. It is scheduled, and we will be availing credit hours for this same conference. We welcome you all to join us on April 13th at 9 a.m. and enjoy the scientific feast and the gala lunch which is awaiting you all. Thank you so much. So as all our participants are pondering over their answers for the quiz questions, we shall now start our meeting with a prayer. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee. SAH prayer. Almighty Lord, the source of pink health, we submit our heartfelt gratitude for healing the dreadful and the chronic patients through our hands. Bless our Sundaram Arulaj hospitals with all the doctors and staffs. Let them shine up in their efforts to heal the sick and develop the science of medicine. We thank you, O Lord, for picking us for health services to create the healthy longevity for healthy citizen and healthy, vibrant India. Thank you. So we shall now start our CME. We have a small change. We will first have the first session for this evening will be on the interesting case of a chest pain, which will be presented by our final year DNB postgraduate, Dr. Dinesh, and discussed by Dr. Alan Benny, our consultant cardiologist. Over to you, Dr. Dinesh.
Good evening, everyone. Today we are going to discuss about an interesting case of chest pain. So coming to the history, a 68 years old female presented with complaints of chest pain and giddiness for one day. Each episode was acute in onset, occurs for less than few minutes, increased on exertion and resolves spontaneously on taking rest. There is no history of reeling sensation, imbalance while walking, no history of oral fullness, tinnitus, hearing difficulty, not associated with headache, nausea, vomiting, photophobia or phonophobia, no history of weakness of limbs, loss of consciousness, or any abnormal movements, bowel or bladder incontinence. There is no history of palpitations, sweating, arm pain, no history of breathlessness, orthopnea, and PND. Coming to the past history, the patient is a known case of hypertension for the past 5 years on regular treatment. Patient is also a known case of hypothyroidism on tablet Thyronam 100 microgram. And the patient had a self-fall at home about 15 days ago and was diagnosed to have pelvic bone fracture in outside hospital. And there they advised the complete bed rest for the patient. So the patient is in complete bed rest for the past 15 days. Coming to the personal history, patient is a non-smoker and alcoholic. He consumes veg diet. Occupational history is a housewife and have a sedentary lifestyle. So coming to the clinical possibilities, coronary artery disease, acute coronary syndrome or any arrhythmias, posterior circulation stroke, postural hypotension, peripheral vertigo including sinobronchial syndrome, and pulmonary embolism due to DVT that could be due to prolonged immobilization. And coming to the
Doctor, excuse me, Dr. Dinesh, can you hear
yes,
me?
yes,
Can you go back to your previous slide?
yes,
Yes, okay. So patient was having exertional chest pain, relieving
yes,
with rest.
yes,
There is no history of any breathlessness. Patient was not having any dyspnea, right?
yes, sir.
Only chest pain is the complaint.
Yes, yes,
Presenting complaint is only chest pain.
chest pains.
Okay, great. So patient had a fracture in the hip, pelvic
sir.
fracture, right? Can
Yes,
you
sir.
go to that slide? Anything like was it treated or anything? Any surgery was done or
No, sir. There was no surgery.
conservative management?
Only conservative management, sir.
Conservative management, pelvic bone fracture.
Yes, sir.
So can you go to the next slide?
Yes.
Yeah. So in a patient with pelvic bone fracture, would you like to suspect a postural hypotension as a possible DD? Patient will be at bed rest.
Yes, sir.
So postural hypotension, I think, may not be
Okay.
an appropriate DD in this patient. So
Okay, sir.
it could be a acute coronary syndrome. That is the most important possibility. Then
Okay,
patient is having a giddiness. So yes, okay, TIA can be a possibility. Vertigo is good. Pulmonary embolism, and that too without even shortness of breath, less likely because you said no shortness of breath, right?
Yes, sir.
Yes. Okay. So only exertional chest pain relieving with rest. I think I will
Yes.
vote only for a coronary artery disease first in this
Okay.
possibility.
Yes.
Yes. Okay. Next.
Okay. Okay. So coming to the examination, general examination, patient is well built and nourished. There is no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Swell, there is swelling, redness, and tenderness over the both calf muscles. And coming to the vitals, temperature normal, blood pressure 90/60 in the right upper limb in supine position, pulse rate 105 beats per minute, and respiratory rate 18 beats per minute, thoracoabdominal type.
Saturation SpO2
The SpO2 is normal, so 97%.
97%
Yes.
SpO2.
Yes.
Respiratory rate is 18. Okay. Great.
Yes. Coming to the systemic examination, cardiovascular system S1, S2 here. There is no other murmurs except for the loud P2. And respiratory system, normal vesicular breath sounds and bilateral laryngeal were equal. Central nervous system and abdomen were normal. Coming to the investigation, HB 11.2, total count was 10,000. Differential count, neutrophils 80%, lymphocyte 14, and eosinophil 6%. ESR 15 and 35. Blood sugar 143, HbA1c 5.3. Urea and creatinine were normal, and the lipid profile were normal. And the troponin levels of the patients were raised of about 2,455, and the D-dimer were also raised about 1,800.
Can
And the,
okay. Yeah. Yes. Okay. Proceed. Proceed, sir.
and the ECG showed sinus tachycardia, and chest X-ray showed a prominent right descending pulmonary artery, and the X-ray pelvis showed fracture of the right superior and inferior pubic ramus. There you can see the fracture.
Doctor, ECG is showing, I think, a little more findings there, not only sinus tachycardia.
Yes,
Lead one and AVL having a downsloping
yes,
ST depression is there.
yes, yes,
Yeah. Some ischemic changes is there. Right.
yes.
Okay.
And the echo showed LV EF of 55%, moderate to severe tricuspid regurgitation, mild concentric LVH, severe pulmonary hypertension, right dilated RA and RV with LV diastolic dysfunction. And the CT pelvis showed slightly displaced oblique fracture of the superior and inferior pubic ramus and undisplaced fracture of right sacral lung. So in view of elevated D-dimer, we did a CT pulmonary angiogram which showed filling defect in the main pulmonary artery bifurcation, right and left pulmonary arteries and their lobar, segmental and subsegmental branches.
So, Doctor,
And
this is a probable case of then you are going in the direction of acute pulmonary embolism, right?
yes, sir.
Okay, okay. But few of your findings, clinical findings, are literally,
Yes,
slightly
sir.
not correlating. SpO2 of 97% in a patient with acute pulmonary embolism, that too filling defect in the main pulmonary artery bifurcation, literally like a saddle embolism. So that is actually not correlating. And respiratory rate of 18 in a massive pulmonary embolism, BP 90/60, heart rate 110, 108. So respiratory rate, I think, is also, I think, should have been on the higher side.
Okay.
Yeah, right. Okay.
And the venous Doppler of both lower limbs showed acute DVT involving the both lower limbs. And the serum fibrinogen, homocysteine, protein C, protein S levels, and factor V laden, antithrombin, APLA profile were normal. And the final diagnosis, acute massive pulmonary thromboembolism, DVT, both lower limbs, secondary to immobilization, fracture of superior and inferior pubic ramus of pelvis, hypertension, hypothyroidism, and dyslipidemia. And the treatment, patient initially started on low molecular weight heparin and antiplatelets, IV antibiotics, beta histone, and antiemetics. And we thrombolized the patient with injection alaxin 30 milligram IV with Avil and Hydrocat 3 medications. And the patient was started on injection Lupinac 60 mg subcutaneous BD for 5 days post thrombolysis. And the patient was started on tablet rivaroxaban 10 mg BD after 5 days of low molecular weight heparin. And the follow-up CTPA showed decrease in the extent of bilateral pulmonary arterial thrombus and mild decrease in the size of dilated RA and RV. Venous Doppler of both legs showed complete resolution of the DVT. Course in the hospital, a 68-year-old female patient presented with complaints of chest pain and giddiness. Initially treated as CAD. CTPA was done in view of elevated D-dimer levels and dilated RA and RV in echo. And diagnosis of acute pulmonary embolism secondary to both leg DVT due to immobilization was made. The patient was thrombolized and started on low molecular weight heparin, followed by NOVAC, discharged in stable condition. So discussion. Pulmonary embolism is a blockage in the artery of lungs by a substance that has moved elsewhere in the body through bloodstream, mainly blood clot. A small proportion of cases are due to embolization of air, fat, and amniotic fluid. Symptoms include dyspnea, tachypnea, chest pain, which is of pleuritic in nature, cough, hemoptysis rarely, and cyanosis can be seen in severe cases. And dizziness can be seen due to reduced cerebral perfusion. The signs include pleural friction rub, which may be audible over the affected area. A pleural effusion may be sometimes present, which is of exudative. Strain on the right ventricle may be detected as a left parasternal heave, a loud pulmonary component of the second heart sound, and under a raised JVP. A low-grade fever may be present. And large pleural effusion, which tend to large centrally, typically cause dyspnea, hypoxia, lower blood pressure, fast heart rate, and fainting. The risk factors include those who undergo orthopedic surgery or at or below the hip, and pancreatic or other colon, other cancer patients, patients with high-grade tumor, pregnancy, patients who are on estrogen medications, and factors affecting the properties of the blood, including genetic thrombophilia such as factor V Leiden mutation, prothrombin gene mutation, protein C, protein S deficiency, antithrombin deficiency, and acquired thrombophilia such as antiphospholipid syndrome, nephrotic syndrome, or paroxysmal nocturnal hemoglobinuria. And this is the modified Wells criteria for the prediction of DVT. If the score is more than 2, it predicts DVT. And coming to the diagnosis, the blood test include in people with low or moderate suspicion of pulmonary embolism. Yeah, normal D-dimer level is enough to exclude the possibility of thrombotic pulmonary embolism. Troponin levels are increased between 16 to 47% with pulmonary embolism. ECG will show sinus tachycardia, which is the most common finding of pulmonary embolism, with a characteristic finding include S1, Q3, T3 pattern and RV strain pattern. Chest X-ray may show Fleischner sign, which is a prominent right descending pulmonary artery. Hampton's thumb, which is an area of impact in the edge based over pleural based over the lungs, and Westermark sign, which is pulmonary oligemia. And the echo will show right RA-RV dilation in massive pulmonary embolism, maybe normal in mild or submassive pulmonary embolism. It will show McConnell sign, and the CTPA will show the filling defects. And in very rarely, we can go for ventilation perfusion scan, which will be
What is McConnell sign, doctor?
So there will be hypokinetic RV with hyperkinetic apex of the elevation. Okay.
So free wall RV free wall hypokinesia with apical
Yes.
and basal sparing. Yeah.
Yes.
Both the base of right ventricle and apex of the right ventricle will be contracting. Only the free wall of the right ventricle will be hypokinetic.
Yes.
Okay.
The treatment include thrombolysis in massive pulmonary embolism with hemodynamic instability in selected cases of submassive pulmonary embolism, pulmonary thrombectomy, surgical or catheter based for patients with bleeding risk, anticoagulation in the form of low molecular weight heparin or newer oral anticoagulants, IVC filter for prevention of recurrent pulmonary embolism. So why this case is presented? So elderly female with a history of fall and prolonged bed rest with complaints of chest pain and palpitations with the elevated tropi and D-dimer. Echo showed dilation of RA and RV. Doppler and CTPA confirmed the diagnosis of venous thromboembolism. The patient thrombolized with injection alaxin, and the patient condition improved and discharged in stable condition. So take-home points: all chest pains are not acute coronary syndrome. Elderly patients with prolonged bed rest leads to DVT and pulmonary embolism. Sudden increase in the size of RA, RV size, I always suspect pulmonary embolism, and it's a treatable and preventable condition. Thank you.
My suspicion, doctor, according to your history, with an exertional chest pain relieving with rest, and a ECG showing an downsloping ST depression in 1 and AVL leads. So my suspicion is still, I think, I will work the patient for coronary artery disease.
So
This is a well-managed case. Patient presented with acute pulmonary embolism. You have managed that well. Okay, good.
Yes.
But always pulmonary embolism is a pan-cardiovascular syndrome. It is actually a pan-cardiovascular syndrome. It can include a whole body inflammation, vascular inflammation. Patient can have concurrent coronary as well as cerebral vascular events. So it can cause any major organ vascular event. So it is a pan-cardiovascular syndrome. So I still would like to work up the patient for cardiovascular coronary evaluation, maybe after a period of stabilization.
Yes, so there is a plan to coronary angiogram after some.
Yes, definitely. Yes, patient needs that. So, and in more than 50% of the patient, echo will be normal. And in more than 50% of the patients, lower limb ultrasound and Doppler studies also will be normal. It is a high risk of clinical suspicion only that can make out the patient for a diagnosis towards pulmonary embolism. Any patient with pneumonia or a heart failure not responding to conventional appropriate therapy, then you should consider underlying pulmonary embolism. And the chest pain also in pulmonary embolism will be most likely a kind of pleurisy pain, which can be positional, which will be localized and varies with respiratory efforts, not likely with exertion, most likely with respiration or with positional variation. And then coming to the evaluation part, is there any use of VQ scan? Ventilation perfusion scan?
VQ scan, we are not using routinely in clinical practice, but if there is any contraindication to use CTPA, like in pregnancy,
yes, renal failure, contrast allergy, VQ scan will be helpful. MRA is actually very less sensitive. It is not widely practiced. VQ scan will be the next option if CTPA is not being considered. So what will be the complications of pulmonary embolism sequelae? What can happen to the patient in due course of time? What all you will expect?
So the patient may develop chronic thromboembolic pulmonary hypertension.
Very good. Yeah. Then?
It may lead to right heart failure and carpal.
Yes, very good. Then anything else? What is post-thrombotic syndrome? Chronic venous insufficiency of the lower limbs.
Yes, the valves will develop due to incompetence. Valve incompetence and venous insufficiency.
Yes, and then what about post-pulmonary embolism syndrome, post-PE syndrome, related to more or less like CTEPH, chronic thromboembolic pulmonary hypertension. And then patient can have a recurrence, and any contraindication for the use of NOACs, high bleeding risk patients, then you go for IVC filter to reduce the recurrence of the patient. Yes, great. Well managed case, doctor.
Yes,
nicely presented. Thank you. Thank you.
We thank Dr. Alan sir and Dr. Dinesh for the well presented and discussed case. As of now, we don't have much questions in the chat box. Delegates, if you have any queries, you can unmute yourself and you can ask. If there are no more queries, you can also post it they can also take it at the end of all the sessions. We thank once again Dr. Alan sir and Dr. Dinesh for the well presented case. And we shall now move on to the second session, which will be on Sparkles 5. case series in dermatology, which will be presented by Dr. Dadayu sir, a senior consultant dermatologist.
Good evening, sir, and everybody. So today I am presenting a series of dermatology cases which will be useful for your clinical practice as well as for physicians to evaluate certain skin problems in systemic diseases. So we'll move on to the case. The first case is painless inflammation. Here we present a 57 years old lady who presented with swelling and redness of the face alone for 2 weeks. And it was sudden in onset and it was progressive in nature. And there were no any systemic symptoms, and there was no any hypoesthesia, no nerve thickening or tenderness, and no trophic changes were seen. And this is the picture of the patient. You can see the well-defined erythematous plaques in the face. You can see the intervening normal skin in between. And she had a lower motor type facial paralysis of the left side. So can you guess what is the diagnosis in this patient? No nerve thickening, no hypoesthesia. So we'll go on. So here it is B.T. Hansen's disease with the type 1 reaction. So here the patient presented only with skin lesions and the inflammation was involving only the skin lesions. So the clue to this diagnosis is the presence of facial paralysis. So this was the clue which will tell you it may be due to Hansen's disease. And the patient was started on multi-drug therapy, multibacillary type, clofazimine, rifampicin, and dapsone was given, and it was to be continued for 1 year. And she was put on steroids, dexamethasone 8 milligrams IV OD, along with the NSAIDs and eye care since she had mild lag of ophthalmos, and bed rest and physiotherapy for the facial muscles. So you can see the response after 2 weeks. This is a remarkable improvement in the type 1 reaction, and even the facial paralysis has improved in this patient. And she is continuing her anti-leprosy therapy, and steroids are being tapered, and it will be reduced to almost nil in future. So early diagnosis and treatment will prevent deformities in leprosy. So this case is presented, but not for its rarity, but for its different presentation. So one more finding in this patient, you can see the picture, normal looking picture. You can see hyperhidrosis. You can see the hyperhidrosis in the neck area. It is just going on, dribbling to the chest. So this is called compensatory hyperhidrosis. So this will indicate, though she is not having any paresthesia or sensory loss, there is an autonomic neuropathy throughout the periphery of the skin. That's why she is having a compensatory hyperhidrosis. This is just an accident, finding which will support your diagnosis. So second case is a pain in a painless disease. Here we present a 47 years old male with the transient and evanescent recurrent painful skin eruptions of 1 month duration. So new crops of lesions occur every 48 hours and it subsides after 48 hours to recur again in a different site. And this was associated with systemic symptoms like fever, joint pain, malaise, and severe tiredness was there. And he was having tender neuritis. So can you guess what is the diagnosis? So diagnostic point here is that the patient had succulent dome-shaped lesions, the papillary lesions in the anterior fold of axilla, right axilla, and in the breast area also. So this was actually a dome-shaped lesion, asymptomatic lesion. So this is a typical lesion of histioid-Hansen's disease. Though histioid-Hansen's disease is a very stable disease, it is usually reactions doesn't occur. Here it has occurred. So this is a case of histioid-Hansen's disease. The histioid-Hansen's disease is nothing but a type of lepromatous leprosy presenting with type 2 reaction, that is ENL type of reaction. Here again, the patient was started on multi-drug therapy along with steroids and NSAID and is improving at present, is under a treatment. So next is case 3. Here we present fox-bitten flesh of a patient. So chronic asymptomatic plaques were present in this patient, and it started 2 years back after a trivial trauma, road traffic accident, very mild trauma. It happened and it was progressive in nature. So here it was healing in one end and it is progressing to the other side. So this exactly will give you the exact clinical diagnosis. Any lesion which heals at one end and progressing to other end is always a cutaneous tube unless and otherwise proved. And Manto test was strongly positive with ulceration, and biopsy revealed a tuberculoid granuloma. So a diagnosis of tuberculosis vericosa cutis was done in this patient, and the patient is referred for surgery for debulking of the lesion and ATT. So next we'll move on to the other case. So here we present a case which is now an endemic in almost India. Every 10 of the skin OP consultations will be this case. So here we present a female patient with facial lesions, which was gradually expanding in nature and it was itchy in nature. And she was prescribed topical steroids and it was expanding in nature. Can you guess what is the diagnosis of this patient? So the diagnostic clue for this patient is the margin of the lesion. So you can see a geographic margin. It is well defined. It is irregular with excoriated papillovesicular eruption in the margin. So this is a steroid modified dermatophytosis, that is tinea faciae, presenting in a different manner. So similarly, another child was brought along with this patient, and here again the presentation was same. Large expanding itchy lesion, and it was of 1 month duration, and history of treatment with topical steroid. And similar illness in almost all the family members had such sort of lesion. So this is again, you can see the very clear margin of the lesion. So it is geographic, irregular, and excoriated papillovesicular eruptions are there. So when such a margin is seen, don't apply corticosteroids for this patient. It will make the lesion large, and it will make it resistant to antifungals also. Similarly, another this is the same patient. So here you can see the lesions in the abdomen also. So dermatophytosis in children is quite rare, and when it is the family is affected, you can get large lesions in the skin. So treatment is with the antifungals, fluconazole, itraconazole, grisofulvin, you can give. But nowadays the treatment regimen has been modified. So a regular 4 to 6 weeks treatment is not useful for the present day dermatophytosis infection. You give antifungals continuously till the lesions heal. And you have to continue 2 weeks beyond clinical cure. So this is the regimen now it is followed. So treatment with the antifungal should be continued 2 weeks beyond clinical cure. Why this 2 weeks beyond clinical cure? Because when you treat with the antifungals, the fungus goes in for spore formation. And these spores will germinate and it has to feed on the skin within 10 days. Otherwise, it will die. So that's why you give antifungals for 2 more weeks. So next case. So pearls of peril. So here you can see a 27-year-old promiscuous male presenting with asymptomatic pearly white dome-shaped papillar lesions with central umbilication. So this is a clear-cut viral infection, molluscum contagiosum. The classical dome-shaped lesion with central umbilication will give you the clue. Whenever it is present in the male genitalia or a female genitalia, or it is present in the face in an adult, it is always an STD. So whenever you find such a case, you have to look for other STDs. This is a viral STD. So you have to look for other STDs and you have to treat for other STDs and look for other STDs also. So this is genital molluscum contagiosum. So it has to be treated physically like extubation, or it can be cryocautery, electrodesiccation can be done, or we can go for cryocautery also. So the disease will be modified in HIV disease. The lesions will be very large. Extensive lesions can be there. and lesions will be very large, even to the size of a tomato, it can increase. So that is giant molluscum contagiosum. So it can be easily modified by HIV disease. So next is an interesting case. Here it is a 40 years old mason who presented with itchy progressive lesions in the back. He has a habit of lying on sand, wet sand. So can you guess the diagnosis? So diagnostic clue is that the lesion is migrating. You can see the linear lesions which are migrating. So this is larva migrans. So larva migrans usually happens in people who come in contact with moist soil. So the clinical picture will be diagnostic, and treatment is with ivermectin single dose, 200 micrograms per kilogram body weight as a single dose, or albendazole you can give. You have to give 400 milligrams OD for 3 days. So lesion will subside after 1 week. So you have to wait for 1 week for the lesions to subside. So next case is a systemic manifestation, cutaneous manifestation of a systemic disease. Here we present a 45 years old lady who presented with asymptomatic brownish and blackish skin lesions, especially over both the legs, over the shins. So she was a diabetic patient, most of the time uncontrolled, and it was there for almost 10 years. So this is a case of diabetic shin spots, otherwise called as diabetic dermopathy, and it is a manifestation of microangiopathy. So once such sort of skin lesions are diagnosed, you have to look for microangiopathic lesions elsewhere, especially in the eye, kidney, and in the heart. So this is an indicator for microangiopathy elsewhere. So treatment is with blood thinners and control of diabetes. So it is important because it reveals microangiopathy in other organs also. Next case. So here again, a 50 years old diabetic male who was diabetic for 2 years presented with generalized itchy eruptions of 3 months duration. So here the lesions are papular lesions, and most of the papules are follicle centered. And when you see a papule very close up, you can see it is conical and there is a small ulceration in the summit. When you press, there will be a small extrusion of cheesy material from the papule. So this is a rare case. So this is perforating folliculitis. So perforating folliculitis is degeneration of the hair follicle through which the hair follicle material is eliminated transepidermally. So this can be a manifestation of diabetes. It can be seen in renal disease also. So there is one another closely resembling disease, that is Kyle's disease, which is which will manifest in chronic renal disease. The only difference is that it will not be follicular. Here it will be follicular. So this again is a cutaneous manifestation of diabetes mellitus. So treatment is with antioxidants, vitamin E. You can give vitamin A or retinoids, and topical keratolytics and control of diabetes will help this patient. Next case. So this is another rare case. This is very rare to see, and this picture is this is the first time I've taken a very classic picture of this condition. A 60 years old diabetic lady presented with multiple asymptomatic lesions in both the legs. So the lesions were erythematous in the margin, and the inner margin was slightly yellowish, and then brownish, and then somewhat whitish, and then grayish. It is almost looking like a cut wood grain appearance. So this is a classical picture of a necrobiotic condition, that is necrobiosis lipoidica. So most of the time it happens in diabetic patient, but this is actually, it's not an exact marker for diabetes mellitus. This again is a necrotic or necrobiotic disorders, which involves the lipid layer as well as the collagen layer of the skin. So this is necrobiosis lipoidica. So this case is being presented for its clarity, and it's seen nowadays in many patients. So it not only happens in diabetes, it can happen in normal individuals also, and it can happen in obesity, severe obesity, hypertension, hyperlipidemia, thyroid disease, and sometimes in collagen vascular disorders also. So next case. So here we focus a patient with giant melanocytic nevus with recent onset of a vitelliginous lesion in the melanocytic nevus. So what is significant about this? So vitiligo is due to autoimmunity directed against a melanocyte. So when it happens, in a giant melanocytic nevus, it will reflect that the melanocyte site is getting altered. So the patient may develop vitiligo throughout the body, that is vitiligo vulgaris can develop. And the important thing is that this will indicate the development of a melanoma in future in such patients, because giant melanocytic nevus patients are prone to develop melanoma. And if there is a vitiliginous patch, you have to screen the patient repeatedly for identifying a melanoma case. So this picture is focused only to tell you what to anticipate in such a patient. Thank you for your patient listening. Your queries will be answered.
Thank you, sir, for your excellent case presentations, clinical cases, and the great points of discussions that you have taught us today. The topic is open for discussion. So we have one question from Rahul. I think they've answered your questions, whether it is sarcoidosis or dermatophytosis, sir. If any of
Which
your
is
slides-
the first case, or?
I think it's from Rahul. Rahul,
Oh.
are you present? You can unmute yourself, Rahul, for the first case, sir. Yes, good.
First case is dermatophytosis. D.T. Hansen's disease is a type 1 reaction.
Okay, sir. Yes, good.
Sarcoidosis, actually, it's an important differential diagnosis. But thing is that sarcoidosis onset will be a bit gradual, and small lesions will occur, and gradually it will increase into a large lesion. And more than a plaque, it will be a nodular lesion, especially in the skin.
I think Jervin also has answered that same question only, sir. And colleagues, you have any other question to sir? You can unmute yourself and ask him. So if there are no more questions, we thank Dr. Dadius sir for his excellent presentation and the clinical cases we had seen today. And we shall now move on to the last agenda of today, for which we request our chairman sir to give his concluding remarks about both the presentations and also to discuss the answers for the clinical album. Over to you, sir.
Good evening to all. First of all, let me start from Tadayus. I always appreciate the clinical acumen of Tadayus, because he always puts it into vision. See that maximum you will touch it and come to a conclusion, which will be proved right in various other investigations that we may do. The leprosy is a disease which is now often forgotten. Lepromatous and tuberculosis all very rare. I too happen to see a leprosy with some deformities recently. She had come for some other thing. Then I was telling our postgraduate, leprosy always lives with us. He has proved it excellently. He has explained the facial nerve and other skin problems. Second common chronic disease is diabetes. The diabetic thermopathy is a very important entity. Once it comes, it stays. Only solution is you will have to see that diabetes is kept under control. And excellent examples he has said. And the fungus also was totally different. And always when there is skin lesion, immediately either patient goes to shop or the clinician prescribes a steroid ointment. That is not the way he has conveyed it. We should really appreciate the continued clinical acumen of our Tadayus. Now coming to our pulmonary embolism, that case discussion was very good. Our postgraduate has done it well. But beyond that, Alan Benny has really, tightened him by putting forth a lot of queries into that. And his terminology of a pan-cardiovascular syndrome was very interesting, because it is a vascular entity, especially in a senior citizen with hypertension, hypothyroidism. And there is a D-dimer is elevated and tropi is also elevated. And there are some ST changes. If you see, I was even suspecting some ST elevation in ABR. Therefore, needs a coronary artery evaluation. Though heparin and antiplatelets control that also, but we need to do that. Thanks for his discussion, Alan Benny. He has got a good future. Now coming to the, clinical cases, the first case, if you see the, ECE, there are two important things that are seen here. See, there is a low voltage complex below 5 millimeters, low voltage complexes in limb leads. And you see here pulses paradoxes. This is normal, this is smaller size. This should immediately make to think that the case that we are dealing with is a pericardial effusion unless fluid arise. Now, these are all the things. Then there is, non-pulsatile JVP. JVP is elevated, usually pulsatile. When it is non-pulsatile, you should think that it is only a pericardial effusion with an early tamponade. And the third thing is the heart sounds are muffled. Even with this clinical picture and ECG, you must be able to make a diagnosis of pericardial effusion, fairly, medium to large effusion. In effusion, always you should say that whether there is an effusion. You must say what is the quantity of effusion. Where is the effusion? There comes the echocardiograph. Will tell you, because heart pericardium is, it is adherent in multiple areas. Therefore, the fluids will be there near the right ventricle and it may not go into the left ventricle. It is all loculated. And you see the X-ray, this is the cardiomegaly. Shotomotor solvo, water bottle sign. Though it is a little different from a water bottle sign, there is a huge heart. What I used to stress more is enlarged heart, cardiac cell out with the normal lung fields. The upper lobar veins are not provident. Always give the first diagnosis to pericardial effusion unless proved otherwise. Echo is the golden rule here. You see here, moderate pericardial effusion. You can also say what type of effusion, whether it is transudate or exudate, there are additions, lot of things where it is blood, we'll be able to say that. Then it is a moderate pericardial effusion. Common cause of moderate, usually the pericardial effusions are tuberculosis. We can do a small aspiration, send the fluid and evaluate for tuberculosis. It is positive. Anti-tuberculous therapy with some doses of steroids will always do that. Now the message here is electrical alternates always think for pericardial effusion with the low voltage complexes. This is a lady, a senior citizen who has got some blood pressure, some diabetes, all medical problems, came to me with a toe which is blackish. We checked the peripheral pulses were not there. Then it is a peripheral arterial disease. And immediately we did an arterial Doppler, no flow was there. I wanted to open it up because there is some blackening started on the other foot also. We did a angio here, a CT angio, see here, completely, totally blocked here, totally blocked here, totally blocked. The treatment of choice is, as we do a coronary angioplasty, peripheral angioplasty can be done. Now she is on heparin, improving. She is waiting for peripheral angioplasty. Coming to this case, somebody, then again a senior citizen falls are very common. We have to train them to be very careful. He fell down about 3 minutes ago and he had some headache and giddiness. Then you must immediately think there any intracranial bleed. Intracranial bleed, because somebody, old man, fallen down and he just gets up and keeps moving. After some time, he develops giddiness and then headache. We should think that there should be intracranial bleeding. You see here, there is a large subdural hematoma with a midline shift. When there is a midline shift, no compromise. And in subdural bleeds, you don't go for, the diuretics or dehydration of the brain measures. It will increase the bleed. Immediately, you will have to, open up here. You will have to put a burr hole here, put in take out all the blood clots, and then, open the dura and take it out, put in a catheter and see that whatever blood is there, that is draining out. That is what done by our neurosurgeon. An excellent job is done. Though there is some fluid here, this is normal fluid. Very little fluid, CSF only. Whereas here, this is blood clot. This will, dissolve in course of time. When there is a headache after a fall, always think for a subdural hematoma. The investigation of choice is a CT scan of the brain. Don't wait for an MRI. Somebody, an elderly lady, has a very big tongue. All of them have very big mouth. Here she has a very big tongue, which we call it as a macroglasia. Macroglasia, very common in thyroid. You see here, the thyroid is very high and the TSH is very high. That shows she has hypothyroid. There are many causes, other causes like amyloidosis, Down syndrome, angioedema, vascular malformation. But commonest, when the tongue is filling up the entire mouth opening, I used to say, think that it is hypothyroidism causing a macroglasia, which sometimes it may go for a sleep apnea syndrome or a speech difficulty also. Before that, you will have to treat it. Sometimes we may have to do a surgical corrections. Macroglasia, consider hypothyroidism. Here it is a skin lesions. He has a history of taking an antibiotic. It's a very classical drug-induced rash. And simple and antihistaminic, a single dose of steroids will make it. A drug rash always comes from the history only. Either you will be going on evaluating, you will be discussing with the other use. But if you have the history and this rash, and it immediately we will vote for a drug rash and gets controlled with antihistaminic and a single dose of steroid. This is usually asymptomatic people. Some of them may have some giddiness. You see the PR interval, which has to be at least 0.12. It is very, very, very short. Very, very, very short. Short PR interval. We call it as a Long-Denong-Levine syndrome. There are two entities. One more entity also having a short PR interval, but there will be a delta wave. There will be delta wave in the ascending limb of the QRS that shows a Wolff-Parkinson-White syndrome. All of them are asymptomatic, usually goes well. Very rarely need some allopant, something like that. But it is ideal. Scientifically, when you speak, it is ideal. You submit the patient for a electrophysiological study and some ablations may be needed. There may be some accessory pathway that gives a permanent relief for the patient. Somebody having an abdominal pain with the amylase and lipase are elevated and alcoholic, you should always consider the first possibility, not gastritis, but pancreatitis. Gastritis is simple, but always keep it in mind in pancreatitis, unless proved otherwise. The investigation of choice, I have said many times, it is a CT scan, it's a gold standard. Simple ultrasound also can always show the head is elevated, the duct is dilated, body, tail are all enlarged. But CT is very classical. See, the intracystic portion is also dilated and irregular, enlarged. That is an acute pancreatitis. Can be a recurrent pancreatitis also. Based on that, you start the treatment, and if need be, you may have to do an ERCP, and sometimes some surgical therapy also may be needed. This picture is to show you that the gold standard for diagnosing is a CT of the abdomen. See, here is a lady with there are a lot of terminologies which are coming up, DCLD, all those things which I am not familiar. A decompensated chronic liver disease. This patient has little disturbance of consciousness. In a chronic liver disease, when there is a disturbance of consciousness, you will have to think whether the patient is going in for a pre-hepatic coma. Always evaluate the ammonia level. And in these patients, we should always be very, very careful. The loss of consciousness may not be persistent, continuous. Sometimes comes, sometimes goes. Here, this lady was taking some fluids when she was, having a defective consciousness that she has aspirated. Now she has a lot of fluid, the right side more than the left side. This aspiration has brought her to a hypoxic respiratory failure. The SpO2 is only 76 and ABG was also abnormal. The treatment is you will have to clear the bronchial tree with a transbronchial aspiration or catheter, and then put some ventilator support, non-invasive ventilation. Patient improves well. Hypoxic respiratory failure is very common in hepatic encephalopathy, needs a ventilatory support. Thank you all very much. As Aarti said, the 13th we have our physical CME ACME. Every year we do that. Due to non-availability, we used to do that in March. due to some of the key faculties, we have shifted to April 13. I think information will reach all of you. Pass on the message to all our colleagues and let us all meet together for a physical meet, our ACME. Thank you all. Good night.
Thank you, sir, for your valuable clinical discussion. We thank our colleagues once again, and we shall meet again in May 2025 with another few interesting clinical discussions. And once again, for all those who have joined a little late, we welcome you all for ACME 2025, which is taking place on April 13th. As sir had said, credit hours will be availed. Join us on April 13th. Good night to one and all.